All right, today we're going to dive in and decode lumbar spinal stenosis. It's one of the most common reasons people get back and leg pain, especially once they're over 50. If you've ever had that weird pain when you're walking that just magically gets better when you lean forward on, say, a shopping cart, well, this explainer is going to show you exactly what's going on. Let's get into it.
This quote, "This is everything." It's not just a complaint, it's like the main clue in a great detective story. For any clinician, hearing a patient say this sets off all the alarm bells, but in a good way. It points right to a very specific problem in the lower back. And figuring out why that shopping cart provides so much relief, well, that's the key to cracking the whole case.
So this shopping cart sign actually has a medical name. It's called neurogenic claudication. And honestly, it is the absolute hallmark symptom of lumbar spinal stenosis, or LSS for short. The pattern is what's so important here. Standing or walking brings on the pain, but sitting or bending forward makes it go away. This is a huge exam point because it's what separates it from something like vascular claudication, where leg pain from bad blood flow is relieved just by stopping, no matter what position you're in.
Okay, so what is physically going on inside the spine to create this super specific kind of pain? To really get a handle on the problem, we've got to take a quick look at the anatomy.
I want you to just picture this. Your spinal canal is basically a protective tunnel. Your vertebrae form the walls, and its whole job is to give a safe, open path for your spinal cord and all the nerves that go out to your legs. In a healthy spine, it's a nice, roomy tunnel with no traffic.
And here is where you can really see the problem in action. On one side, you have a normal, open canal. Plenty of space for the nerves to just hang out and do their thing. But on the other side, in a stenotic canal, that tunnel has gotten way narrower. It's basically a traffic jam, and those poor nerves are getting pinched and compressed. That pressure is the root cause of all the trouble.
So, what are the culprits causing this narrowing? Usually it's just the result of degenerative changes that happen as we age, classic wear and tear. We're talking about things like bone spurs on the facet joints, or a thickening of a key ligament called the ligamentum flavum, and of course, bulging discs. All these things slowly start to move in on that tunnel, leaving less and less room for the nerves.
So, how do we actually diagnose LSS for sure? Well, it's a process of real clinical detective work. And it doesn't start with some fancy scan. It starts with something much more fundamental, listening to the patient's story and doing a really good physical exam. All right, let's put on our clinician hats for a second. Based on everything we've talked about so far, what's the one clue from a patient's story that would make you think, aha, this is probably LSS? It's really all about connecting those dots. And here's the evidence. According to some really important studies, some clues are way more powerful than others. For example, if a patient has a wide-based gait, that has a likelihood ratio of 14.3. That means they are over 14 times more likely to have LSS. Another big one is if they have absolutely no pain when they're sitting down. For any clinical exam, these are the high-yield findings you'd be looking for.
Now for an absolutely critical exam point. Sometimes what you don't find is just as important as what you do find. The straight leg raise test, which is a classic test for sciatica from a herniated disc, is usually negative in someone with spinal stenosis. That's a huge clue. It tells us the nerve irritation in LSS is positional. It's about being crowded when you stand up, not from being under constant tension like with a big disc herniation. Okay, so once the clinical suspicion is super high based on the story and the exam, what's the next step? We need to actually look inside the spine to see the narrowing for ourselves and confirm our diagnosis.
And the gold standard for doing that is the MRI, magnetic resonance imaging. It's simply the best non-invasive way we have to get a super detailed look at all the soft tissues, the nerves, the discs, the ligaments, and to see exactly where and how badly that spinal canal is being squeezed.
Now, when radiologists look at these scans, they're not just eyeballing it. There's a key measurement they look for. A cross-sectional area of the dural sac, that's the little sleeve that holds all the nerves, of less than 100 square millimeters is a pretty well-accepted sign of significant stenosis. It's how we put a real objective number on how narrow that tunnel has become. But what happens if a patient can't get an MRI? Maybe they have a pacemaker or are really claustrophobic. Well, the next best option is usually something called a CT myelogram. Now, it's a bit more invasive because it involves injecting a contrast dye into the spinal canal, but it gives incredible detail, especially of the bony structures that might be causing the compression. So, the diagnosis is confirmed. Now what?
Well, the path to feeling better isn't just one single road. It's more like a ladder. You always start on the lowest, least invasive rung, and you only climb up to the next one if you absolutely have to.
That first rung, the foundation of all treatment, is conservative care. We're talking about things like physical therapy, especially exercises that involve bending forward, modifying your activities to avoid pain, and using anti-inflammatory meds. If that isn't cutting it, we can climb to the next rung, minimally invasive options like epidural steroid injections to help calm down that nerve inflammation. And then the final step, only for when nothing else works, is surgery to decompress the nerves.
And you know what? For a whole lot of people, conservative care really does the trick. This chart shows what happens in the long run. If you look at patients who stick with non-operative treatments, only about 20 to 40% end up needing surgery down the line. A big majority, somewhere between 50 and 70% of the rest, either get better or find their symptoms just stay stable for years. It proves that starting conservatively is a really smart strategy. So, when do you actually pull the trigger on surgery? It's really reserved for very specific situations, like when the pain becomes truly disabling and just isn't getting better after months of conservative care, or if someone is developing serious neurological issues like major leg weakness. The goal of the surgery is pretty straightforward: physically open up that tunnel and give those nerves some breathing room. But there is one hugely important exception to that surgery is the last resort rule. It's a rare but very serious complication called cauda equina syndrome. The symptoms you see here are absolute non-negotiable red flags. Any new loss of bowel or bladder control, or that severe numbness in the saddle area, that is a true surgical emergency. It requires immediate medical help to prevent permanent nerve damage. So let's just quickly wrap this all up. What are the key takeaways? Number 1, lumbar spinal stenosis is a narrowing of the spinal canal, and it's super common as we get older. 2, the classic symptom is neurogenic claudication, that leg pain that gets better when you bend forward. 3, the diagnosis is a puzzle you solve with the patient's story, a good exam, and you confirm it with an MRI. And finally, treatment is a ladder, always starting with conservative care first. And that kind of leaves us with a bigger, more philosophical question to chew on. Given that this is all caused by the natural aging process of the spine, is stenosis an inevitable disease that we have to fight tooth and nail? Or is it maybe just a really common part of the human condition that we learn to manage? It's definitely something to think about as we all look for better ways to stay mobile and live well as we get older. Thanks for joining me.